Hi, this is Yazan Daaboul, live from the American Heart Association in Chicago, and I'm pleased to be joined by Dr. Ishani, who just presented the results of chlorthalidone versus hydrochlorothiazide in hypertensive patients. Dr. Ishani, thank you so much for joining us.
Thanks for having me.
So tell us a little bit more about, the debacle, hydrochlorothiazide versus chlorthalidone. What's the hypothesis here? What's the unmet need for the trial?
Yeah, so historically, there's been a number of studies that have suggested that chlorthalidone reduces cardiovascular outcomes compared to placebo. The level of evidence for hydrochlorothiazide was not as strong. More recently, there have been some studies that have suggested that chlorthalidone is associated with better 24-hour blood pressure control compared to hydrochlorothiazide, as well as other pleiotropic effects.
It's a longer-acting medicine?
It is longer-acting, yes. There have been some more recently 2 observational studies that have, shed some doubt on this. These observational studies have suggested maybe there's no difference in cardiovascular outcomes and potentially more adverse effects with chlorthalidone, including more hypokalemia, acute kidney injury, and chronic kidney disease.
So tell us a little bit more about the design before we go over the results.
Yeah, so this is a pragmatic trial. And so what we did was we were up at 72 VA medical centers. We had no study staff at any of the sites. There was no case report forms. What we did is we consented the providers. We really tried to leverage the electronic medical record system. So the consent to the providers was through the electronic medical record system. We obtained verbal consent from patients. What we then did was we then either left them on, so they had to be on 25 or 50 milligrams of hydrochlorothiazide. We either left them on that drug, or we then switched them centrally to chlorthalidone, sent that back to the primary care provider to sign the order. And then everything after that was usual care. So what that means is the pharmacy filled it, so it was not a research medication. The primary care provider was responsible for the thiazide, whether it's chlorthalidone or hydrochlorothiazide, and they were responsible for all hypertension management. What we did was we passively followed individuals through the electronic medical record as well as claims to identify events, and that's how we did the study.
What did you find?
So what we found was that, so in general, baseline characteristics were well matched. It was an older population by design, so average age was 72 years. This was a VA population, so 97% were male. It was a very inclusive population, so 15% African American and 45% were rural. We recruited from all over America. Mean blood pressure was about 139. And then over the course of the trial, there was no difference in mean blood pressure between the chlorthalidone group and the hydrochlorothiazide group. Similarly, if you looked at mean potassium, no difference between the 2 groups. If you looked at the number of people on potassium supplements, they both started about 11%. It increased in the chlorthalidone group to about 13% and stayed stable in the hydrochlorothiazide group.
Was hyponatremia a problem for either of them?
So we looked for adverse events, and there was no difference between the 2 groups in the incidence of hyponatremia. So for our primary outcome, again, so for a major adverse cardiovascular event or non-cancer death, there was no difference between chlorthalidone and hydrochlorothiazide. So, and the hazard ratio was 1.04, so no signal. And if you look at the components of the primary outcome, similarly, no difference. So no difference for MI, stroke, heart failure hospitalization, urgent revascularization, or non-cancer death.
Hypotension, was that a problem for either drugs or both?
So as I said, so blood pressure was equivalent in both groups over the course of the study. I do want to highlight one thing, is we did a priori specify 8 subgroups we were going to look at kind of when we wrote the protocol. In general, there was no difference between chlorthalidone and hydrochlorothiazide for any of the subgroups, so age, gender, race type thing. There was one subgroup that was different, and there was a significant P for interaction, so 0.008, that persisted when you adjusted for multiplicity. And it was a qualitative in that individuals with no history of MI or stroke tended to have an increased risk of the primary outcome when they were randomized to chlorthalidone. Conversely, individuals with a history of MI or stroke, that's about 11% of the population, did better on chlorthalidone compared to hydrochlorothiazide for the primary outcome, with about a 27% reduction in events. Again, how you interpret a subgroup that's qualitatively different in the context of a negative trial, it's hard to understand. This may be a chance finding, but I think this is where future research should focus.
Is there a plan for more studies on chlorthalidone?
So I'm hoping to do something. So specifically in the subgroup with MI or stroke, because if there's a 27% benefit, that would be significant. And so I think to do a second iteration of this study and focus really on individuals with a history of MI or stroke.
Well, thank you so much for sharing the results of the trial. And thank you all for joining us live from the American Heart Association.